Now, today we are going to discuss the COVID-19 infection. This is the pandemic of this century, which has affected the global community in a lot more different ways. That the lifestyles have changed, the economic impact of this disease, the health impact of the disease. We are going to divide this presentation into two sections. Today, we are going to discuss briefly about the history, how this disease is transmitted, who are the individuals who are more vulnerable, what are the usual clinical features, how do we investigate these patients, and what complications they can have. Now, about the history, you see SARS-CoV-2, or the severe acute respiratory syndrome coronavirus 2 infection. This was reported in an outbreak of respiratory illness in the Wuhan city of Hubei province of China in the last months of 2019. You see, it was reported to WHO in December 31st of 2019 year, and in January 30th, 2020, it was declared as a global health emergency. On February 11th, 2020, the Coronavirus Advisory Group officially designated this as SARS-CoV-2, that is Severe Acute Respiratory Syndrome Coronavirus 2. And then on 11th March 2020, this was declared as a global pandemic by the WHO. The illness caused by this SARS-CoV-2 virus is called Coronavirus Disease 2019, or we know it famously as COVID-19. So SARS-CoV-2 is actually the virus, and COVID-19 is the illness caused by the virus. Now, how this virus is transmitted? The most important route of transmission is by droplet spread. That is, whenever an individual speaks, coughs, or sneezes, there is a release of micro droplets, which can travel to a distance of approximately 6 feet, depending upon the force of ejection from the respiratory tract, and then they fall down. So an individual who is carrying the virus and another individual comes in contact and is within 6 feet of that individual, he has a chance of getting this infection. The second is contact transmission, like shaking hands. For example, if an individual carries the virus on the hands and another individual shakes the hands with that affected individual and then touches without washing the hands to the oral mucosa, the nasal mucosa, or the ocular mucosa, that is conjunctiva. So this virus can be transmitted from the hands to the mucous membranes, and then it can cause illness. And the third transmission is airborne secretion coming in direct contact with the mucous membranes. That's why when we are examining the patients who got COVID infection, that is coronavirus infection, the protection of the eyes is quite important. Fomoid transmission is that these droplets, they settle on inanimate objects. For example, door handles, the buttons on the elevators, the railing of the staircase, or on the chairs or table, or similar things. And from these, the virus can be theoretically transmitted, but it has been seen that this mode of transmission is quite inefficient. So the main route of transmission is respiratory droplets, and then contact transmission. And an unusual cause or uncommon cause is the contact of the droplets directly with the mucous membranes. Now, virus shedding and duration of transmission. Now, how long an individual remains infective? What is the duration of virus shedding? So, virus shedding actually does not mean, or it's not synonymous with the transmission of infection. Some of the individual may be shedding virus, but they may not be efficient enough to cause infection. You see, adults with COVID-19, they remain no longer infectious after 10 days of their symptoms if the disease is mild to moderate. So if they do not have severe illness, they have mild illness, or they have moderate illness, they remain infectious. That is, they can transmit the infection to other individuals up till 10 days of their symptoms. Patients who are severely or critically ill, or those patients who are severely immunocompromised, they keep on shedding the virus for longer periods, say up to 20 days. For adults with no symptom, Isolation and other precautions can be relaxed 10 days after their first reverse transcriptase PCR is positive. So if the PCR for SARS-CoV-2 is positive and they are not symptomatic, then after 10 days, those precautions can be relaxed. The test may remain positive, that is, the PCR may remain positive for very long durations, but the individual may not be symptomatic and patient may not be transmitting infection to others. So the symptom-based isolation policy looks more prudent than the lab-based isolation policy. That is, patients who do not have symptoms or they have passed 10 days after the onset of their symptoms, they are not infective and the isolation can be stopped. And this policy is better than the test-based policy because many individuals can keep on shedding the virus for long periods, even up to 30 days, that may not be infective. So that's why a symptom-based policy of isolation is more appropriate than the lab test-based isolation policy. Now, who are the individuals who are at risk of complications? Because this disease generally is mild, but it can result in severe complications, and there are certain group of people, or that is segments of population, that can be affected by the disease more severely than other people. For example, patients who've got underlying serious comorbid conditions. The comorbids may be, patient may be having cancer or malignancy, patient may have chronic kidney disease, or there may be chronic obstructive pulmonary disease. The patients who are having heart conditions like heart failure, the coronary artery disease, or the patients have cardiomyopathies. And patients who have received solid organs, that is solid organ transplant state, these patients are on immune compromising drugs. Then patients who are type 2 diabetics, smokers, obese patients, pregnancies, a vulnerable situation, patients who've got sickle cell disease, they have increased chances of having complications. Then incubation period. Incubation period is that the time after the exposure of the individual to the development of clinical symptoms. That is, if the patient is exposed to day 0 to the SARS-CoV-2 and the patient develops symptoms, the symptoms may be on second, third, fourth, or fifth day. So this is called incubation period. That is the time between the exposure and the first clinical manifestation. So incubation period varies for this infection from 2 days to 2 weeks, but we generally see that the mean incubation is 5.1 days, and almost 97.5% of the patients, they are affected within 11.5 days of the exposure to this virus. So as the time passes, that is after the 11th day, the chances of having clinical disease, they are less and less, even if the individual is exposed to the virus. Now, clinical presentation. You see 81% of the patient have mild symptoms. They may be absent, they may be mild pneumonia, or they even may be totally asymptomatic. 14% have severe illness, that is, they have hypoxia, they are breathless, and you see within 1 to 2 days, more than 50% of their lungs may be involved by the infecting process. 5% of the patient are critical, that is, they may have shock, they may have respiratory failure, or they may have multi-organ failure syndrome. And 2.3% patients have fatal illness. Now, what are the symptoms of these patients? There are usual symptoms. These may be composed of those feelings called by viremia, that is, symptoms caused by viremia. A generalized viremia can cause fever or chills. There may be fatigue. There may be body pains like muscle pains. There may be headache. Then patient may have respiratory symptoms. There may be upper respiratory symptoms like sore throat, there may be runny nose, or there may be congestion in the nose. And then may the patient have the lower respiratory symptoms like cough, there may be difficulty in breathing. Some of the patient may have loss of taste or smell. If there is a recent loss of taste or smell, COVID infection should be considered, and some of the patient may present with diarrhea even. Then patient may have some additional symptom. For example, patient may have malaise. There may be sputum production, although sputum production is uncommon. Patient may have respiratory distress. They may present with headache. There may be altered mentation, and some of the patient may present with abdominal pain that they may have pancreatitis, but this is uncommon. And then physical examination. The physical examination of the COVID patients should be carried out in an isolated room with closed doors, and the examiner should have proper personal protective equipment, which includes protections of the eyes as well, because contact with the eyes, the droplets, they can directly settle in the conjunctival mucous membrane, and then they can be trouble for the examining health professional. So the ocular protection should also be included in the personal protective equipment. Vitals should be recorded, and the oxygen saturation can be recorded from the pulse oximeter. And you see the examination findings are generally very non-specific, and an examination should usually be carried out by mere observation. For example, look for the presence of tachypnea, look for the presence of diaphoresis, increased work of breathing, and there may be retractions of the intercostal, subcostal, or the suprasternal areas. Now, when do we consider that this patient may have COVID or the coronavirus infection? Patients with new onset of fever and respiratory symptoms. Patients who've got lower respiratory symptoms which are severe and which have no other explanation. In these patients, it should be considered as COVID or coronavirus infection. You see, if the patient had contact with suspected or confirmed case of COVID-19 or living in areas with high prevalence or the endemic areas, these patients should definitely be considered from suffering from COVID-19. Now, why you want to test these individuals? Number one, we confirm the disease to detect the SARS-CoV-2 infection and link the patient to the medical care. And the second thing is you want to screen individual to reduce transmission. Those who have got infection, they can be a source to others, but as we saw that now this policy is being changed because a symptom-based policy is more efficient than a lab-based policy, because some of the individuals may be shedding the virus but they still not are infective. Then which patients to test? Not everyone needs to be tested, so we see which patients we should actually be testing. Patients who've got COVID-19 symptoms, it's clear. Those who have got clinical features of COVID-19, they should be tested and confirmed. Close contacts of COVID-19 patients, that is patients who have been within 6 feet of a suspected or confirmed case of COVID-19 for 15 minutes or more in a period of 24 hours. These patients need to be tested for the presence of COVID infection. Individuals who are fully vaccinated, they are without symptoms, they don't need to be tested. Similarly, asymptomatic recovered patients, the patients who had COVID disease, they recovered within 3 months of the initial illness, they need not to be tested again because they may be asymptomatic and they may be shedding virus and they still are not a source of infection. So these two categories who have been in contact with the COVID patients, they have not symptoms, they have been vaccinated, they need not be tested. Similarly, patients who have recovered from COVID disease within 90 days, they need not to be tested again. People at high risk for exposure, for example, people attending large social or mass gatherings or living in crowded indoor settings, they should be tested. People who have been advised by the health professional and the health authorities, they should be tested. Now, which diagnostic tests are available and which diagnostic tests should be used? You see, we can have viral RNA detection. This should be done within 3 to 10 days of the onset of the symptoms. Similarly, this test is high sensitivity and high specificity test, and the turnaround time is usually 1 to 3 days depending upon the type of method used by the laboratories. And there is a point of care test which can give result in 15 minutes. Then we can detect viral antigens. They are less sensitive, but they are as specific as viral RNA. They have a short turnaround time of say 15 to 30 minutes. They may require confirmation in some cases. For example, patient may not have symptoms and the test may be positive, or the test may be negative and the patients may have symptoms. In those cases, this needs to be confirmed. And then antibodies detection. These antibodies are used to detect a previous infection. And keep in mind one thing, seroconversion does not imply that the patient is immune to the disease. So these not for sure confer the immunity. Now, which test to select? Now we've got these two different tests, that is reverse transcriptase PCR and antigen detection. Now, for reverse transcriptase PCR, we need nasal, nasopharyngeal, sputum or saliva as the samples. So the swabs can be taken and tested. For antigen detection, we use nasal and nasopharyngeal secretions test. The sensitivity of reverse transcriptase PCR is high for lab-based and it's moderate for the point-of-care test. So the lab test, which utilize the technique, has a high sensitivity as compared to the point-of-care testing. The antigen detection problem is that they have a sensitivity which is moderate to high when viral replication is at the peak, but when the replication is at the lower ebb, the antigen detection has a modest or moderate sensitivity. The specificity of both these tests are quite high. This reverse transcriptase PCR and the antigen, they have high specificity. The advantages of PCR are that they detect the current infection, but the problem is the turnaround time is 1 to 3 days. But as I mentioned, some of the point of care tests, they can give you a result within 15 minutes. Similarly, the antigens, they have an advantage. They can detect the current infection and the turnaround time is usually between 15 to 30 minutes. Disadvantages, PCR is costly and it may be positive in convalescence. That is, the patients who have recovered from the illness, the PCR may still be positive. Similarly, the antigen detection, the disadvantage is that it may need confirmation testing and it is less sensitive in asymptomatic patients. The PCR is more sensitive in asymptomatic patients. Now, the third one, the antibody testing. Why we use antibody testing? You see, one thing is the less than 40% of the patients are positive for antibodies within 6 to 7 days of onset of the symptoms, and then the antibody titer starts rising. The other problem is the cross-reactivity with coronavirus that makes interpretation difficult, because these antibodies may be similar to the antibodies produced by other type of coronavirus infections. So with this antibody test, we may not be able to differentiate this is the current infection is caused by SARS-CoV-2 or some other type of coronavirus infection. The antibody testing should be monitored 2 weeks apart to look for the presence of a rising titer. If the titer is rising, that means the current infection is caused by one of the coronaviruses. They are usually used for community studies. They may not be helpful in making a diagnosis of the patient who is having active disease. So for active disease, we use either the PCR or the antigens. Then we got some non-specific lab findings. For example, some of the patient may show leukopenia, the others may show leukocytosis, there may be lymphopenia. The lactate dehydrogenase and serum ferritin may be increased. Similarly, the C-reactive protein and D dimers may be raised in patients who got complications. We can check for the procalcitonin for the presence of superadded bacterial infections. Procalcitonin is low in viral infections, or it's normal, while in bacterial infections it tends to be high. So one can check for procalcitonin. Similarly, we can look for other inflammatory markers like interleukins, but they're generally not required. Now, what are the indicators of bad prognosis in patients who are hospitalized? Older age, neutrophilic leukocytosis, elevated LDH and elevated D dimers. These are indicators that the patient may have more complications among the population which is hospitalized. Now we can go for certain imaging studies like CT scan and chest X-ray. CT scan is a very important investigation which can pick up early disease, small volume disease, which may not sometimes be picked on a chest X-ray. You see, what do we see on CT scan? The appearance, usually classical appearance, is the ground glass haziness, or there may be consolidation. So the patient may have ground glass appearance, or there may be consolidation on CT scanning. The other features include generally it's peripheral location of the disease. This may show fine reticular pattern, and there may be vascular thickening. The combined central and peripheral distribution, effusions, and lymph node enlargements are unusual. They are not feature of COVID disease. You see, they tend to have peripheral small lesions. They are away from the parenchyma. They are not close to the parenchyma. They are close to the periphery. So we actually see, as the disease progress, evolution in the CT scan. In the early phase, we see there are multiple small interstitial shadows which appear near the pleura or bronchi. They are not seen in the parenchyma. And then in the progressive phase, these lesions, they coalesce, become large and form large ground glass opacities. And patients who got severe disease, there may be massive pulmonary consolidation. And then there is a dissipative phase in which the exudates, or the shadows, or the opacities, they start absorbing, and they're becoming less and less, and the patient may have the initiation of fibrosis at this stage. And you see the radiological investigation, they always lag behind the clinical investigation. So the patient may have clinical problems, and then patient may have radiological appearance relevant to these clinical situations. So the radiological investigations not only lag in the appearance of the symptoms, and again they remain there even after the symptoms have resolved. So they lag behind the clinical course of the disease. And then we can do a chest X-ray which can show us bilateral lower zone consolidation. There may be ground glass appearance, and the pleural effusions, they are not usually seen with the COVID disease. The cardiomediastinal silhouette is usually normal unless the patient has cardiomyopathy and the heart may start dilating, and there may be features of heart failure. Otherwise, in patients in home, there is no cardiac involvement. This may not be a problem. Then complications. You see 70% of the patients who are hospitalized, they are hospitalized because of pneumonias. There may be acute respiratory distress syndrome in 15% of the patient. Patients may have cardiac injuries including arrhythmias, heart failure, myocarditis, raised cardiac troponins in 10 to 15% of the patient. There may be septic shock. There may be liver injury in 19% of the patient. 9% of the patient may have acute kidney injury. There may be multi-organ failure. There may be prothrombotic coagulopathy. There may be venous and arterial thrombosis in 10 to 25% of the patient. And you see the patients who are in the ICU, the case fatality is almost 40%. So these are the different complications of COVID disease. And in our next lecture, we'll discuss how to prevent the disease, how to treat the disease, how to monitor during treatment, and what are the consequences of this illness. We close our discussion about the COVID disease with this slide.